So I thought it might be really memorable for some of us who have been in midwifery for a while to take just a brief moment and remember someone so important to the business of midwifery whose funeral is this weekend in Texas, Nancy Jo Reedy. For any of you who had the pleasure of knowing Nancy Jo, um, she was one of the most, I would say, modern midwives who moved us into really appreciating and understanding the value, the fiscal value of midwifery, alongside all the other incredible things midwives do. And Nancy Jo's passing a few weeks ago is tragic to many of us who knew her very well. So I just wanted to quickly remember her tonight, um, and make this session in honor of her. So, Arden, I'm going to let you take it away.
All right. I will share my screen and we will get started. Um, there is a lot of information that I am going to cover tonight, and I know my eyes glazed over as I was writing this, so I fully expect that it will be a lot for everyone else as well. Um, Okay, can everyone see my screen? Perfect. So tonight or today, we are going to really focus on prenatal care and billing for prenatal care under the 2027 CPT guidelines. And not just billing, but charting, coding, billing for prenatal care. And the reason why we are focusing heavily on prenatal care tonight isn't because labor management and delivery don't matter. It's because we don't have clear guidance yet on labor management and delivery as we move into 2027. In addition, billing prenatal care per visit starts September 1st. For anyone newly pregnant entering care on or after September 1st, those claims will all be billed per visit. So everyone should get in the habit of charting your visits so that it's based on time or medical decision making with E&M codes so that your billers can bill per visit. The legalese, this presentation is for educational use only. The CPT codes are a registered trademark of the American Medical Association. They are who develop the CPT codes, they are who publish them, and they are who decides what the definition is and how we should use them. And I will tell you that guidance around the 2027 coding changes frequently, and it will change based on payer specifics as well as what CMS releases in the final rule in September, which hopefully they release it in September. So as a refresher, what has changed in the new CPT codes are global maternity code. Global maternity is gone, effective January 1st, 2027. It is being replaced by billing prenatally or billing per visit, prenatally for antepartum care. Labor management will be separately billed. And then you're billing for your delivery, whether it's vaginal or C-section, and postpartum care will be billed per visit. A big question everyone has when it comes to the new guidelines and billing prenatal care per visit is, will each visit have a copay? And to answer that, I did research on the Public Health Services Act, HRSA, and the Affordable Care Act, as well as other regulations. and any group health plan or health insurer offering group or individual coverage at minimum is required to provide coverage for preventive care and screenings for women, as well as prenatal care. So pre-pregnancy, prenatal care, postpartum, and inter-pregnancy visits without copay or coinsurance. The exceptions to this are grandfathered plans, so any plans that existed before March 23rd, 2010, which is less than 13% of employer plans, any short-term or limited plans, any high deductible health plans, and some self-funded plans. If the plan is self-funded, the patient has the option, or the employer has the option to opt into or out of offering essential health benefits at 100%. On the self-funded plans that do not offer essential health benefits at 100%, it states that either on the back of their card or when you check benefits. And then all fully funded plans are required to offer preventive, prenatal, and well woman services at zero cost share. So, how do we best prepare to chart our prenatal visits as we go into September and go into the new 2027 guidelines? You will be charting using E&M codes based on medical decision making or total time. So, in talking to a lot of our billing service clients, other midwives, a few OBs, the biggest thing that I have heard is that the traditional SOAP note does not help tell the story of what happened in the prenatal visit. And one thing that is really important as you are moving into 2027 and you are charting these prenatal visits, and whether you're coding them or your biller's coding them, it is important that each prenatal visit tells the story of what happened in that visit, because that is how they are billed. So in a traditional SOAP note, which I'm sure you're all familiar with, it's subjective, objective assessment and the plan. And routine visits may simply read as patient here for routine prenatal visit, everything is great. But that doesn't tell the story of what actually happened in the visit. Now, you can take your traditional SOAP note, and this is what we're going to talk about tonight, and you can flip it a little bit so that you are charting based on the evaluation, so the problems, the status, and then the orders or the plan. So your assessment then becomes first, or your evaluation. That will demonstrate the work and the medical decision making that was performed. Each condition is actually evaluated and managed and is named as a problem. Your data and your management decisions are tied to the problem, and it shows exactly what you've evaluated, even when the pregnancy is progressing normally. But the biggest takeaway with this is it answers the coder and the health insurance company's auditors' questions of what problems did you address in that specific visit? What was the patient's status? What data did you review? And what management decisions did you make? The structural loan, and one thing to keep in mind is we're working through this tonight, and as you're working through it clinically, the structural loan never creates a higher E&M level. You have to make the work visible. The services, the problems, the data, and the risk have to support the code for your biller. So here's a side-by-side prenatal example to help paint this picture or put it into play. So a 30-week prenatal visit with obesity complicating pregnancy, iron deficiency anemia, and Rh negative. In a traditional SOAP note, The subjective is the routine prenatal visit, denies VB, LOF, or contractions, taking iron, no HA, no visible changes, home BP normal. The objective is the blood pressure, the fetal heart rate, the vertex, etc. The assessment, IUP 30 weeks, obesity, anemia, and the plan is to continue prenatal care and iron and continue aspirin, Rogam as indicated. But it doesn't paint the whole picture. It doesn't paint what all was done in that visit. Where if you flip it and you chart it with your evaluation first, 30-week evaluation, denies VB, LOF, or regular contractions, etc., you address your problems. Prenatal at 30 weeks, obesity is complicating pregnancy, anemia is complicating pregnancy, Rh negative status. These 4 problems that you've addressed all translate to a diagnosis code. Status or your medical decision making. What medical decision making did you use in this visit? Pregnancy, and according to ACOG, pregnancy is a moderate level of medical decision making. Reassuring fetal assessment, reviewed the increased risk that obesity presents. Blood pressure is reassuring, so you'll continue surveillance. Anemia, the HGB was 10.8, treating it with oral iron, and the patient's tolerating it. Rh negative, and discussed Rogam timing and administration. And then what is your plan moving forward? So the goal is not to make a longer note. The goal is to make a more intentional note. And for anyone who is using client care or maternity neighborhood or mobile midwife, for example, and you have your flow at the top and you're charting below, the goal isn't necessarily to take away your flow. Your flow is still important, but you have to actually define what you used for medical decision making. And I see.
Yeah, we have a couple of questions in the chat. Carly Waller wanted to know about the starting care on or after September 1st, meaning those who've already started care would mean what exactly?
So if someone is entering care newly pregnant or within the first trimester on or after September 1st, you are probably not going to have enough visits to bill global prenatal care on December 31st. Instead, you're going to bill per visit because they will deliver in 2027. And starting January 1st, all of those visits will be billed per visit. Some of the payers have already issued guidance around this. Aetna is one of them. Aetna's latest maternity policy states anyone entering care on or after September 1st, 2026 is billed per visit with a TH modifier. And so it's important that whoever's responsible for billing in your practice is keeping an eye on the payer policies. Right now, Aetna is and a few Medicaid plans are the only ones who have released their payer policies. But as we move into September and then the fourth quarter, more will be releasing their policies.
And then, Carly, like an APSO note versus a SOAP note, which is correct, except for they're calling it EPSO.
Yeah, EPSO, APSO, it doesn't, the acronym really doesn't matter. It's more how the note is. And like in this example, this was from an ACOG training that I attended, and in talking to other providers, they labeled it with an E for evaluation. If it were me, I might label it with an A for assessment and just flip my SOAP so that the acronyms are still there, but your assessment is first, because that more directly ties into how most people are used to charting maternity. or
And
prenatal care.
Ginger, remind me, we're going to have 30 minutes at the end for the questions. So we're going to hold
Yes.
the remainder of the questions until the end.
Yeah, we have a lot of slides, so we want to make sure that we get to all the slides and as many of your questions as possible. So here I actually took the E, changed it to an A because in my brain it makes more sense. So assessment, you are assessing the gestational age, pregnancy status, active complications that were addressed in today's visit. That is the big takeaway with this. When you're billing prenatal care per visit, history of doesn't necessarily come into play if that history of is not affecting what's happening in today's visit. Like, for example, history of preterm labor. You're in the first trimester. They haven't had any history of preterm labor in this current pregnancy. They didn't have it in the pregnancy before this, but they did in their first pregnancy. That is not it should not be taken into consideration for today's assessment. Their current status, are they stable, worsening, are they at goal, not at goal? And then a short clinical interpretation of the findings. What is your plan? For each problem, are you going to continue, start, stop, change medications, order testing, surveillance? Are you referring out? Document why. Capture any counseling and follow-up or any escalation. And then your status, that's your medical decision making. So the status of each problem, is it stable or worsening? Are they at goal, not at goal? And what is the medical decision making behind that status? Did you interpret data? Did you review anything? What are your reasonings behind today's decisions and the risk of management of this pregnancy as it's happening today? And then what's your plan moving forward? Are you ordering any new labs? Are you referring out to MFM? Are you asking them to continue, start, stop, or change medication? Any testing, surveillance, referrals, and then any counseling or follow-up. So how does this translate to selecting your codes based on time or medical decision-making? I know that up until now, and this change of billing maternity care per visit, whether the time was spent or the medical decision-making didn't really come into play because everything was billed globally unless it was a problem-focused visit that was outside of routine or global maternity care. Now it's documentation is key. So the 3 MDM elements are problems addressed, what was evaluated and managed, the data reviewed, tests, records, interpretations. What is the risk, the morbidity risk, the mortality risk? What is the risk of today's decision? Risk is even prescription management. And then does it fit into a low, a moderate, or a high MDM? Based on medical decision making, does your 99213, 214, 215 fit in the low, moderate, or high? Or does it fit better in the total time? And if it fits better in the total time spent with the patient, that is your total time spent face to face, as well as your total time on the date of the encounter reviewing charts or notes and your charting. And in order for it to be a 99214, for example, your total time spent needs to be a minimum of 30 minutes. And then this slide is an example of how you can take a pregnancy and fit it into the different levels, whether it's straightforward or low is going to typically be a nurse visit for like a urine dip or just listening to fetal heart tones or drawing blood for labs. Most routine prenatal visits are going to be either a 99213 or a 99214. And then I just added some common prenatal diagnosis codes because as we move into this new way of charting, it also means a new way of coding, maybe for you, maybe for your biller. If it's for you, you'll want to make sure when you're looking at the medical decision making, you're also coding it appropriately. So if the pregnancy is truly normal, there is not one complicating code that fits better. You'll use the Z34 codes with the Z3A for number of gestational weeks. But in most cases, you're going to use an O code, whether it's obesity, advanced maternal age, GDM, etc. So now, this was the fun part for me, coming through or going into some charting examples. So we're going to go through some examples, and the chart notes in the before that you are seeing are actual chart notes that I was either sent from a midwife or an OB, or that I pulled and redacted all the PHI from accounts that we bill for. So these are actual what the chart note looked like before and then what it should look like going forward. So before, this is a routine prenatal visit, complete uncomplicated pregnancy. So 20 week, 3-day return OB, doing well. Blood pressure is normal, fetal heart rate 140, etc. Anatomy is scan normal, return to clinic in 4 weeks. So if you're charting it for medical decision making friendly, you would want to chart your assessment. So IUP 20 week, 3-day, progressing appropriately, no maternal fetal complications, anatomy, ultrasound reviewed. Your plan, continue routine prenatal care, reviewed fetal movement, nutrition, warning signs, 24 to 28 week testing, return to clinic in 4 weeks. Patient feels well, regular fetal movement, denies bleeding, leaking fluid, contractions, urinary symptoms, blood pressure is normal, fundal height, fetal heart rate, anatomy ultrasound reviewed. So based on medical decision making for a routine, uncomplicated pregnancy, do you think this would be a low or a moderate? Would it be a 99213 or a 99214? Anyone?
I'm getting, it looks like
3.
1 3s, yeah.
Perfect. This would be a 99213. It's a low risk, only one element reaches moderate decision making. Now, if you spend 30 to 39 qualifying minutes that are documented in the chart, you could select a 99214 based on time. Now let's throw in anemia complicating the pregnancy. So for a medical decision-making friendly chart, you would want to document pregnancy at 30 weeks, 4 days, fetal status reassuring, anemia complicating pregnancy, newly identified. That is key. CBC, HGB 10.4, decreased consistent with iron deficiency. You're starting medication. There's good fetal movement, blood pressure 118/72, fundal height, fetal heart rate, etc. So based on this, would it be a 99213 or a 99214?
Looks like we're getting 1 4s.
14s are correct. This is classic moderate decision making because you have a diagnosis, you have interpretation, you have a treatment decision, and your follow-ups are all visible. In other words, your note tells the story. So now we'll talk about anxiety and depression. Anxiety and depression stable, continues Zoloft, no concerns. Well, that doesn't exactly tell the story in a 25-week return OB. Sorry, I could not get that out tonight. Instead, you want to tell more of the story. So pregnancy, 25 weeks, 0 days, depression, anxiety, complicating pregnancy, stable on pharmacologic treatment, can't say that tonight. PHQ-9 reviewed, adequate control, denies SI worsening. So you're going to continue medication. You talked about tolerability, maternal benefit, the risk of relapse. They're supposed to report worsening mood, SI, medication concerns. You're documenting mood stable, denies panic, significant depression, good fetal movement, blood pressure, etc. So would this be a low or a moderate, a 99213 or a 99214?
Mostly 1/4s again.
1/4s are correct. And the whole point in this is the majority of your prenatal visits, if you tell the story in your notes, are going to end in the 99214, moderate decision making. Why for this one? Because stable can still reflect active management when the decision to continue therapy is documented. All right, hypothyroidism with a medication adjustment. To tell the story, you need to document how many weeks pregnant, 18 weeks, 18 weeks, 3 days. Hypothyroidism, complicating pregnancy, not at treatment goal. TSH increased to 4.6 from 2.8 despite adherence. You're increasing medication. You are repeating testing. You reviewed administration and the importance of adequate replacement. The plan is, that is the plan. The patient's going to continue taking the medication consistently. They have no adverse effects. They're doing well. And you've documented again, TSH went from 4.6 or went from 2.8 to 4.6, and that was reviewed with the patient. Is this a 99213 or a 99214?
You're getting 1/4s.
1/4s are correct. And this is a very clean example of moderate decision making. We only have a couple left. Chronic hypertension controlled on medication. The previous note, not enough info. So pregnancy, 28 weeks, 3 days with chronic hypertension controlled on medication. No symptoms of preeclampsia. You reviewed a home blood pressure log. Your plan is to continue medication, continue home blood pressure monitoring, and you reviewed preeclampsia warning signs, and you will continue growth surveillance. Is this one a 99213 or a 99214?
We all here they're coming in now. 1/4.
1/4 is correct. Normal blood pressure today does not erase the fact that you are managing chronic hypertension. And the home blood pressure logs and the medication help support that. In this case, you have preeclampsia with severe features and you are escalating care. The pregnancy is 34 weeks, 3 days. The findings are concerning for preeclampsia with severe features. Severe range blood pressure confirmed on repeat. New persistent HA and visible disturbance raise a concern for severe maternal distress requiring immediate escalation. You discuss the risks with the patient. You determine immediate hospital evaluation is required, you contact L&D. Is this a 99214 or a 99215?
You got a lot of 15s.
A
They were
15
coming
is
in before
correct.
you finished talking.
Yes, anytime that you are referring to the hospital for evaluation, you are referring to an OB, or you are referring to MFM, it automatically jumps from a 214 to a 215. And the last one, we talk about social determinants of health. Social determinants of health was a hot button when they were talking about the codes. The AMA wanted social determinants of health to be a consideration in advancing the level of risk and basically risking people out of midwifery care and into OBs. ACOG stood up for midwifery care and said, absolutely not. We need midwives. So that was nice to hear. So with social determinants of health, I apologize the print is so small, but that was like, all of these things are very important. Pregnancy, 29 weeks, 6 days, diet controlled GDM, fasting above target 4 out of 10 days. Here's where the social determinants come in. The patient has social determinants that are materially limiting treatment. They have a food insecurity, unreliable transportation, cannot consistently obtain or afford recommended foods, missed nutrition visit because they didn't have any transportation, difficulty getting testing supplies, and the barriers are directly affecting the plan. So, as part of the plan, you reviewed feasible dietary options given the foods they have available. You did not start any medication because you wanted to first address access barriers and reassess glucose. You contacted social work or community resource referrals, etc. So, based on this, is this a 99214 or a 99215?
Getting 14s.
14 is correct. You have two moderate elements that are present when you're documenting your social barriers. And the note has to connect the social determinants of health to the direct management of the patient. So in your diagnosis, you would report the pregnancy GDM, gestational age codes, and then the applicable Z55 to 65 codes for food insecurity, transportation insecurity, etc. And what about, well, so first of all, any of the previous examples apply in any birth setting. The prenatal care is not dependent upon the setting of where it takes place. So community birth, hospital-based practice, OB practice, etc. But there are some things in community birth that are specific to community birth. And this is a question that I've received a lot in Facebook comments when we were talking about tonight's webinar, emails, text messages, etc. So I felt it was important that we add in after hours antepartum triage at a freestanding birth center. So the scenario is a patient calls in at 9:15 p.m. with decreased fetal movement, intermittent contractions, and possible leaking fluid. The birth center is closed. Patient arrives at 9:45 and is discharged at 11:30 after you do a maternal assessment, NST, ultrasound, reassessment, and counseling. What is billable? If the patient is not in labor and you are sending them home, the only things that are billable are an E&M visit, an NST, the ultrasound, and some payers will allow an after-hours code. Because the patient was only there for 105 minutes of clock time, you cannot bill a facility fee to most payers. Most payers, your contracts will specifically state that the patient has to be formally admitted to the birth center for a stay longer than 2 hours. And another thing to keep in mind is 105-minute stay, whether it's in a birth center, triage at a hospital, does not equate 105 minutes of evaluation and management time. You count only the qualifying time spent face-to-face with the patient, reviewing the NST, reviewing the ultrasound, consulting with someone else, etc. You cannot count any nursing observation or room time or separately reported procedure time. So if you're coding this based on total time, you could use a 99215, 40 to 54 minutes, plus some payers will allow the prolonged service code. If you evaluate for labor, but the patient is not in active labor, it stays in antepartum care. It stays with a 99215. If the patient is determined to be in active labor and you begin managing labor, then the new labor management codes will come into play and you will bill the labor management code instead of the E&M code. And those are all things that your biller will verify in the chart notes or should verify in the chart notes before billing. Now, for any of you who are here who are involved in running the practice, so operations, profitability, implementation, performance, you might be the biller, you might be the practice manager, maybe you own the practice. This following information is for you. So the best way to prepare yourselves for the new maternity codes is an operational transformation. Before everybody who is not directly involved with running the practice redesigns the notes, I just want to add a disclaimer. If you're working in a larger practice, a hospital-based practice, please check with your administrator or your biller as to how they want the notes handled. Make sure that your every encounter is episode based. Every encounter needs a charge capture pathway before you sign your note. And you need to make sure that you're flagging your notes for telehealth, triage, transfers, etc. Someone should be building a payer-by-payer maternity matrix so that you know the rules for each payer. When are they adopting the new per-visit billing? Are they adopting an alternate methodology of billing? Do they require the TH modifier? Are they covering telehealth for pregnancy? On your ultrasounds and NSTs, are they paying both the professional and the technical component or just the professional? Do they require an authorization? Some of the HCA plans require an authorization. Some of the health exchange plans require an authorization or a PCP referral. Have you looked over your fee schedule, your new allowed amounts, and any claim edits that will come into play? And then there are different rules that you should assign out within your practice. Clinicians should make the MDM visible. Make sure you're documenting your total time. Make sure your notes tell the story. The coders and the billers should be doing an E&M audit. They should come back to you with things that they're finding in your notes that will help you improve your charting moving forward to help increase the revenue of the practice or help you get credit for what you're doing, especially if you're in an RVU-based model. The front desk should be looking and doing verification of benefits, looking at patients' insurance cards, making sure that an authorization or a referral is not required, determining whether or not the visits have a copay. And then someone needs to visit the taxonomy, the revenue, and the contract modeling with each of your payers to make sure that your contracts are ready for 2027. So the 2027 structure does give an opportunity. It makes previously invisible professional work visible. Profitability depends on the global fee, or depends less, on the global fee, and more on accurate encounter capture, documented complexity, payer contract values, and operational discipline. One thing to make sure that you are very careful about is no overcoding. Capture every billable encounter, include appropriate telehealth and triage, and use the appropriate E&M level that's supported by medical decision-making or time. Don't default every visit to one code because not every single visit is going to fit nicely in one little bucket. Ensure your diagnostics have compliant orders and complete standalone reports. Capture your professional intertechnical components correctly. This is really important if you're in a hospital-based practice. If you're doing an ultrasound in a hospital, it's only the professional component. Identify your payer recognized after hours or facility reimbursements, especially in a birth center. And run payer-specific fee schedule analysis before you contract or before you ask for any changes or adjustments to your current contract. Two big traps going into the new codes are undercoding. Using a super brief charting style leaves a lot up to interpretation, not just for you, but also for your biller and coder, as well as for the insurance company. Some insurance companies love to ask for chart notes for every prenatal visit, like United Healthcare. If your notes don't support what your biller is submitting, then they will downcode you. Also avoid systematic overcoding. As we previously discussed, you should not assume that every pregnancy is a 99214 just because pregnancy is moderate. That creates audit and recoupment exposure. You still are required to document 2 of the 3 MDM elements unless you're using total time. You will want to model by your payer, not by the CPT alone. So someone in your practice should be looking at your current average revenue per pregnancy under global billing by the payer, and then what your expected antepartum encounters per pregnancy will equate to under your actual care model, as well as what you will be reimbursed for labor management, the delivery, and postpartum care. Someone should project your NST, ultrasound, triage volume. What effect do transfers have on your practice or shared care, late to care? And what are the denials, underpayment lag during the transition? I fully expect that insurance companies will not be fully prepared for this, and we will see denials. Even with the TH modifier, we are going to see denials when billing per visit, especially during September, October, November, December, because the insurance company's systems, their algorithms are still programmed to automatically deny per visit billing for prenatal visits as included in global maternity that will no longer exist. So how much do you have in your cash reserves? What do you need to sustain in the event that there is a lag in payments or unnecessary denials? And who do you have working those denials? Do you have someone on your team who is responsible for working them and ensuring that your claims do get paid appropriately? This is just a review of what we talked about in a implementation plan. We're about 90 days out, so it's everything we just discussed. But the big thing is, after you go live, who is giving you feedback on your documentation? Somebody should be auditing your charts and giving you feedback. Somebody should be reviewing your denials and underpayments, looking at a weekly dashboard, doing a payer variance review. And then 60 to 90 days after January 1st, somebody should be doing a focused audit of your charting and your level distribution to ensure that you're not lumping everyone in one bucket. On the revenue cycle side, somebody should be appealing the denials, looking at payer edits. How do you optimize those? And then someone else should be updating your contracts. A lot of the insurance companies have a hold right now on updating contracts because they are really focused on trying to figure out how they're going to change their systems to pay these codes. So after the first of the year, somebody should be focused on updating your contracts. Does your staffing need to change? How is your scheduling? Does that need to change? And then there are dashboard metrics that you should be watching internally as well. What's the E&M distribution by clinician and by payer? What percentage of your prenatal visits are coded by medical decision-making versus time? What is your average allowed amount and net collection per encounter? And I would even narrow it down even further to per encounter, per payer. What's your denial rate? Who's monitoring those? Who's monitoring your first pass resolution rate, etc. And then doing an internal audit. If you take away nothing else from this, the pregnancy in and of itself does not have an E&M level. The encounter does. What happened that day is what determines the level. Make sure you're documenting your work, selecting the supported code so that we can measure the results. Now, one last thing, well, maybe two. Before we get into questions, CMS decided that they would just arbitrarily throw into the final rule G codes that replace the proposed deleted global codes. So I ask anyone who has not already to reach out, go and comment on the final rule. Because if we have two sets of codes, whichever set of codes we agree on, we should only have one set of codes. But if we have two sets of codes, one, the new way, everything is per visit with labor management and global postpartum care, or the other are Medicare's new G codes that take us right back to global maternity, it will confuse the payers, you as the providers, the practice managers, and the billers. But most importantly, it will confuse the payers and it will result in more claims not being paid, which will directly affect your revenue. What's coming up next? I will be doing some form of this presentation at ACNM in Kansas City in October. I will be attending ACOG's Payment in Practice conference in November. That is where for an entire day. We are going through cases and coding them, and both CPT code and diagnosis code, to better prepare ourselves for January. And then after I come back from that, I'm going to take all that knowledge and do a third webinar for all of you that covers the labor management and the delivery billing. References, the biggest one, all the CPT codes came from the AMA. A lot of other information came from all of the AMA and ACOG trainings that I have attended over, feels like, years. And now I will open it up to questions.
Do you want me to read the questions for you?
Sure. That'll allow me time to get a drink.
Like this first one may be a Ginger question. Will this recording be available?
I can answer that. It'll be on our YouTube channel. When is a Ginger question, because she does that part, but it will be available on our YouTube channel.
We'll have it up by the weekend.
I'm going to kind of go to the top and come back down because people are typing. Where did we end? I think right here. In Epic, we have a pregnancy episode where we document the blood pressure, fundal height, fetal heart tones, and typically don't pull it into our notes since it is in another section. Do we need to have that in our notes specifically now?
That's really going to depend on what your practice wants you to do. And if a payer requests chart notes from the visit, what pulls to the chart notes? In some cases, you can put like C flow or C episode or whatever. Like, for example, anyone who's using client care, you can put C flow. In Epic, it's not called flow, but you can do the same thing, but you have to document that information somewhere and then reference it in your notes. And whether your coder or your biller wants more information, that's on their discretion.
Jessica Brumley asks, often this would be addressed in between visit. Would that change the billing? I think that was when you were discussing the depression in pregnancy slide.
Mhm. But if
Anemia.
you're,
Anemia. I'm
anemia.
sorry. Okay.
So if you are addressing it between pregnancy, or between visits, sorry, it's in the pregnancy, but then you are discussing it again when they come in for the visit, or it's still part of your current visit. So you can still document what you did in between visits and how that's affecting today.
Okay. What is the significance of newly identified to be in the note? I think in one of them you wrote that it was a newly identified problem.
Because a newly identified problem, according to medical decision making, requires a higher level of decision making, because you're not managing something that you already knew about. You are identifying a brand new problem. So that bumps you up in your medical decision making.
I think you already answered this one, but it was, can you put C prenatal flow sheet instead of typing everything up? Yep. I thought that you answered that. When you said that the intention was not to make the notes longer, that Ann Brooks Hire says it does look as if the notes are longer, even if it wasn't the intended goal. And I agree with that. They were definitely longer.
They are definitely longer. It wasn't the intention wasn't to make the notes longer, but you have to tell the story. So in order to tell the story, unfortunately, you have to make the notes longer. There's no other way to tell the story. And because Now you are basing your code on what happened that day. There's no way to get around it. I really wish that I could give you a way to shorthand all your notes, but unfortunately, I can't.
If you're doing a timed visit instead of the encounter visit, does the charting count in the time?
Yes.
So that's going to make you a
As
30
long as
minute
you're
visit.
charting on the date of the
Right,
encounter.
right, right.
If you are doing your charts a month later, which, gosh, I hope nobody is, but I have seen it happen,
Mhm.
then no, your charting time does not count. Or even the next day, your charting time does not count.
My notes already tell the story just in the SOAP order, not like the before notes that you used as example, but like the after notes. So should I just reorder them to ABSO because they would be telling the same story just in a different order?
No, you can leave them in the soap nor oh, I can't talk. Sorry. You can leave them in the soap order. That is totally fine. And some billers are going to get mad at me for changing the order, and some aren't going to like it. But the whole point of that was just to paint the picture of how you need to tell a story in every visit in order to justify your medical decision making.
Okay. This is your friend Denise. What if the
Hi,
barrier
Denise.
is denial of the diagnosis? I think that was when you were talking about the social determinants of health, correct? Okay.
That's correct.
Okay, so what was the question?
The
What,
question is you said to put the social determinants of health, access to care, like transportation. What if the barrier is denial of the diagnosis?
Then you would note that the barrier is
Is that
denial of the
okay?
diagnosis. I think there's even
That
a
takes a lot of
diagnosis.
time.
I think there's even a diagnosis code for that.
Okay. That'll be good to know. It's the
For
most
you,
exhausting barrier.
I will make a note and look up.
Okay.
you mentioned anytime we recommend someone going to the hospital for evaluation, we should bill 99215. Does this include things like for non-reassuring NST, decelerations on NST, need for further testing for rule outs from, etc.?
Yes, anytime you are referring to a higher level of care, so CNM to OB, CNM to MFM, clinic to hospital, etc.,
So
it
there's a part,
automatically jumps you from a 214 to a 215
there's a part B
because
to that question.
it and the reason why is it makes that visit not necessarily the whole pregnancy. Let's but it makes that visit high risk. And when a pregnancy visit becomes high risk, it becomes a 99215. And that
So
is an ACOG definition.
So instead of a face-to-face visit, this is a triage phone call. The patient calls complaining of decreased fetal movement, and you refer them to the hospital.
All you can bill for is a phone call. You cannot bill an E&M code if all you're doing is talking to the patient on the phone.
Also asked, is it the same if we recommend OB consult next visit for various conditions?
I think it's going to depend on the conditions because you're not directly, the next visit, your level would be increased if the OB is coming in to consult with you. But that visit, no, because the conditions weren't a big enough risk to determine a consult that day.
Another question about MFM co-management during pregnancy, but coming back for routine visits with CNM, like stating pregnancy complicated by GMDA2, co-managed by MFM.
I would have to know more about what happened in the visit to know if it automatically determines a 99214 or a 99215. In some, in a lot of cases, well, first of all, what I would do is print out, and we can send one but I would print out or take a screenshot of the slide with the medical decision-making matrix for pregnancy. And while you're getting used to charting this way, refer to that, because that will be your best friend in determining your medical decision-making.
Does this eliminate incident to billing?
That is part of the goal behind it, I do believe, is to have less incident to billing take place and have whoever is rendering the care directly billing for the care.
Uh, could you go over what a TH modifier is?
Yes, so a TH modifier means prenatal care, and most of the payers are going to require that a TH modifier be added to any E&M code, so 99213 or 5, when you are billing pregnancy per visit. That's what tells the payer this is a pregnancy visit that is not included in global, because global is gone.
Our patients routinely spend at least 30 minutes for each visit with the midwife. If we are billing by time, are there requirements for documentation other than documenting the time?
You have to document your total face-to-face time spent and your total time spent. Excuse me. And one thing I will caution, because I see this a lot in reviewing charts, is to put the exact same time for every patient, because you are not spending exactly 30 minutes face-to-face with every patient. You might be spending 29 minutes. You might be spending 37 minutes. You might, if they're denying their social determinants of health, spend 79 minutes with that patient, but not every visit is exactly the same. And payers audit chart notes, and they audit chart notes frequently. And if you're in a large system and you're using Epic, Athena, Cerner, Elation, even Practice Fusion, charts are being sent to the payers automatically on the back end. They're literally going into your EMR and pulling charts. So I would be very careful of your total time being exact for everyone. Or I mean, being exactly the same for everyone.
How do we get copies of the slides?
We are not sending copies of the slides. The presentation will be on the YouTube channel.
Are we expecting that this itemized billing will increase overall reimbursement? The fact that the insurance companies aren't pushing back makes me concerned that maybe they support it because they can reimburse less.
You and me both, sister. I don't know for sure. So I have taken practices that we bill for and taken their contracted rates and fee schedules and looked at if I did 10 prenatal visits, delivery, and 3 postpartum visits for mom. I did not factor in newborn care or labor management because those are not priced yet. And in every example that I ran, and it was like 30 some, maybe 40, it was either dead even or within $200 of their contracted rate for global. Now, when you factor in the newborn and for anyone in community birth who is seeing their newborns, or you factor in labor management, because that will be billable in any practice setting, it should come out ahead. But I have also heard, sorry, there was a fly. I have also heard rumors that when they release the final numbers for the RVUs, that there will be a decrease overall of the fee schedule. Not just the maternity codes, but every code will see a decrease. I don't know if that's true or not. Everybody likes to speculate, especially in August and September, right before everything is released. And so hopefully we'll know soon. Hopefully we'll know before October, and then I can add it in my slides for ACNM.
Do we use the TH modifier for all prenatal visits, labor management, delivery coding, or is this just a prenatal modifier code?
It's a prenatal modifier code, and it's payer specific. So again, Aetna and a few Medicaid plans are the only ones that have released as of yesterday. I didn't check today. And Aetna, you will use the TH modifier, and the Medicaid plans. ACOG is stating to use the TH modifier on every prenatal visit. So I've instructed my billers for any accounts we bill for to add the TH modifier starting September 1st. Whether I just saw pop up, as long as we're on TH modifier applicable to postpartum visits, it's going to be payer specific. So somebody needs to monitor your payers to determine that.
Can we bill for after-hour phone calls?
That's payer specific. Some payers will pay for a phone call, most will not.
If you are sending someone to labor or triage on the same day as the visit, will that affect the reimbursement for the office visit within the same system? For context, our clinic and L&D are in the same building and patients see the same group of providers in either place.
It is supposed to be the new coding is supposed to be provider specific, but it's also going to be payer specific. Each payer is going to have their own rules, and each contract is going to have their own rules. So you're going to have to defer to your biller for guidance on that, because there's no way of knowing. There's no way I can know for every single system.
Is there any estimate as to when we are supposed to know how labor management and delivery will be billed moving forward?
CMS is supposed to publish the final rule in September. That will determine the reimbursement for labor management and delivery. And ACOG and the AMA should be doing trainings on labor management. I have been getting some of them early, and once we have those, I'll be able to train or do another webinar. But I will tell you that they are delaying the release of trainings on labor management and delivery because those things don't happen until January. And the biggest thing right now that they want people to focus on is billing for the E&M codes for prenatal care, because that starts Tuesday for most payers. Most payers are going to start it Tuesday. Even if they don't publish it by Tuesday, they're going to retro it back, at least in the latest ACOG and AMA guidance I saw.
Is the TH modifier still applicable to postpartum care?
It's payer specific. So typically no, but some payers may require it.
I work for a large hospital organization that has been dragging their heels on getting us official guidance. Likely we won't have anything by 9/1. Do you recommend we start billing like this starting 9/1 regardless?
I recommend that you start telling the story in your charts so that somebody can appropriately bill them today, tomorrow. It's definitely by 9/1. And if you're dropping your own charges, I would drop charges for your prenatal visits, and then your biller can determine if it's billed prenatally or per visit.
How does this affect OON community midwives? We don't have contracts.
No, but if you're an out-of-network community midwife, you will no longer be able to give your patients a super bill for global maternity because there won't be global maternity codes. So it will be starting anybody who delivers starting in January, depending on how many prenatals you had in 2026, you may be able to give them a super bill for global prenatal care and then a second super bill for delivery and postpartum care. So 59410. But if they're just now starting care, it may be that you are giving them a super bill for each visit or at the end of each trimester with the visits separated out, and then one at the end for labor management and delivery. And I already had a call from a community home birth midwife who already had a patient have their global denied.
Mm.
And we're not even in 2027 yet. It's because the insurance companies don't know what they're doing on a good day, let alone when there's changes. Hopefully,
Right.
there's no insurance reps on this call.
Uh, what is the chance this is going to be delayed until 2028?
I don't think it will. I think that the AMA and ACOG have invested a lot of money in getting this to go through now. I could be wrong. I've been wrong before, but I don't think it will be delayed.
Do you suggest we bill for phone calls regardless, then let the specific payer decide?
I would.
Uh, I have a home birth practice and not in network with any insurance plan, so I give the client super bills, but I don't submit claims to insurance companies.
Yep. And that would be just like we talked about before.
And I believe that's the last one. Somebody speak up if I missed a question.
Yeah. Or feel free to,
Oh, here we go. Do you know the CPT for phone calls?
not off the top of my head. My head's a little foggy tonight with all the coding. Don't know it off the top of my head.
I did have a question that just a follow up. So, and I echo, I have for the last several months have gotten when I would give global super bills, they say no, it needs to be billed for each visit, or that, like you said, insurance companies just they're probably in a frenzy. They don't know what they need to be doing. So, um, do you suggest this TH modifier? Because I don't know what I don't, like I don't have contracts. Do you think I should just put it on all of these just, and then if they don't want, I don't know, like I don't know what to do.
So it really is payer and state specific as to how each one is going to want it billed. And really in 2026, so right now, if you, by the end of December, if you have 4 to 6 visits, it should be billed with 59425 for global 4 to 6 visits. And then in 2027, when they deliver, you'll give them a super bill for the labor management codes and the delivery code. Or if they have 7 to 10 visits by December 31st, then it's 59426, and then the labor management codes and the delivery codes.
I think you just answered this question. How many visits need to happen in 2026 versus 2027 for there to be 2 super bills? It sounds like there's a specific number you have in mind. We are out of network home birth practice.
If they deliver in 2027 and had any prenatal care in 2026, it's 2 super bills regardless.
Okay.
Even if the delivery is January 1st.
And then Katie put in 98016 is the code for a 5 to 10 minute phone call initiated by the patient. And it can't be about a visit in the prior 7 days, or cause a EM visit within 24 hours or the next available appointment. Several people have thanked you.
You are welcome.
Typically, when a patient signs on, we complete a VOB and give an estimate with the global codes. That being said, with all of these changes, how would you recommend proceeding with that aspect of things, since those codes will not actually exist at their delivery date?
So when you're doing your VOB, you will need to find out how their plan is. Are prenatal visits subject to coinsurance and deductible and copays, or are they covered at 100%? If prenatal visits are covered at 100%, then their estimate is only on labor management, which we don't have the pricing for yet, and delivery. And then postpartum care would fall under the same as prenatal visits. But it's really important now when you're doing the VOBs to determine whether or not they will have any coinsurance and copay for your E&M visits. If they do, then you need to estimate the number of visits, so that's estimated into your patient responsibility. We have, for our billing service clients, we have like charts for every practice, every payer, every VOB, how it's done, because it is very complicated right now, especially when you don't know how certain codes will be priced.
What if the prenatal visits are in the office, but the postpartum visits are in the patient's home?
The place of service doesn't matter. It's still an E&M code, whether it's a home visit or, I mean, it'd be a home visit code, but the place of service doesn't matter how you chart it. And
Yeah, the next question was also on if all the visits are in the home, but I think you answered that.
yeah, it'll just be the home visit code instead of the office visit code, and the home visit place of service instead of the office place of service. Leslie, thank you for reading all these questions for me.
You're welcome. And so the person who asked about the home visit codes, so not 99213 or 4.
Correct. It would be like 99347, 348, 349.
Lots of thank yous, thank yous, thank you, thank you.
You are all very welcome. I am happy that I can help, even if this makes it 10% easier, because this is a lot of information and there isn't a ton of resources or trainings out there. So if I can help, I am happy to do so.
And look at this, it's 9:22. You finished
Woohoo!
a few minutes early.
Well, and just so everybody knows, I did a practice run through of this yesterday with one of our billing practices, and I had 10 more slides in there. And at the end, I felt like everybody was way too overwhelmed, and it took over an hour just to get through them. So I took them out.
Yeah, you condensed this really well. I wasn't sure how you were going to do it, but you did a good job.
Thank you.
When will you have the exact date for the November webinar?
I need to check Ginger, Leslie, and Denise's schedules based on when I get back from the ACOG training in November. But ideally, I would like to do it before Thanksgiving. before that week, because I know that week is hard for everyone, myself included, to try to schedule things in.
That was going to be my guess. We'll try to get it done before Thanksgiving.
Yep. And the ACOG training is the first Saturday in November. And then I'll just need a little bit of time to prepare something for everyone.
I think Arden maybe sharing the first webinar done in June is up on YouTube now.
Mhm.
Do you think it's better to watch that one first before this one if people are encouraging their colleagues to listen in?
I would watch the first one because the first one does more of setting the framework behind the changes, like why did everything change, what changed, goes into more of that explanation. And this one is more examples on how you should adapt your charting and what your practice needs to do to adapt the billing and the oversight to prepare for right now. And then the third one will talk more about the labor management and the delivery and how you need to best prepare yourselves for January 1st.
The other question I'm sitting here thinking, not as a practicing clinician anymore, is what if I were in a practice, and I think we got a hint of this by a few comments, nobody's providing them any information in these large systems. How and who could they approach to motivate people to guide them, either through how Epic may or may not be impacted, or how their charting should change? Like, how could you encourage them to reach out to people within their system?
So I think you should reach out to, you could always start with your practice administrator, reach out to your biller, find out which one of them is going to be your easiest pathway or your best pathway to get guidance and training. And if they don't know, then find out if you can bring someone in to do training for you. I know I personally have had a few practices reach out to me over the last 2 to 3 weeks wanting quotes on coming in and doing trainings for their staff. So there's those resources out there also. But I would start with your practice administrator and your biller and ask them what guidance they have. In a larger system, they have to have someone who is, I would think, I shouldn't say they would have to, but I would think they would have someone with their finger on the pulse of this who can give you guidance. And if not, I would find out why. In a smaller practice, your biller should be keeping up on these things. And if they are not, I would ask them why. Because that's your revenue, especially, I mean, it's important in a larger practice. I'm not trying to say that it's not, but in a smaller practice, your biller not having a handle on these changes will make or break your practice.
I think we are out of questions and comments, and it looks like we've had a few people go ahead and sign off. So thanks everybody for joining us. Exciting times. We'll see what January brings.
Yes, exciting times indeed, overwhelming times. I don't know about the rest of you, but all of this has my head swimming. I've been overwhelmed for a while with this.